All right. So it is Halloween. Happy Halloween. Happy Halloween to everybody. And let's drop that down and open that up. All right. Isn't candy alarmingly expensive? I was shocked. I mean, considering there is zero nutritional value to that stuff, it is so expensive. I digress. I mean, for that? Ooh, sale tomorrow. Uh, we'll know where to find you, Deborah, tomorrow. If you can't be located, you'll be at the CVS. Excellent. All right, so on that Halloweenish note, we're going to wrap up Unit 5, which is our anxiety disorder slash where we throw OCD in there too. Because there's certainly a strong anxiety distress component to it, even though it's not considered. All right, I kind of wish I had little, candy to give people. Candy, emoji candy. That would be appropriate. So let's go ahead and get started. We actually have objectives. Because that's a great idea, I think. So this is what we're trying to accomplish this evening on Halloween. These are the disorders we're talking about this evening. Separation anxiety, social anxiety, and OCD. Though it's not an anxiety disorder, we're going to talk about it in this context here. Primary features, associated features. So essentially the DSM criteria. And the primary feature is the most important one. Because without it, you don't have the disorder. We want y'all to be familiar with the differences in prevalence. Are these common or not? What's the typical age of onset? Typical course? Are there typical triggers? Are there common comorbidities? Are there treatment similarities and differences between them? And we will briefly at the end introduce distinctions between treatment of pediatric anxiety disorders versus adult. Because again, anxiety disorders may present panic disorder, specific phobia, OCD, GAD. Those disorders can present at a younger age, which makes anxiety disorders different from mood disorders and thought disorders because of their potential for earlier onset. And again, we'll go into much more detail next semester when we talk about pediatrics. So obsessive compulsive disorder. Not a real creative name is necessary. It involves obsessions and compulsions. You have to have one or the other. And most of the time people have both. But that means to say, just if the person has repeated intrusive distressing images or thoughts with no observable, operationally definable behavior, that doesn't exclude them from OCD. OCD, you need the O, you need the C, you can have both. Who in here, because I know we got a few folks working in an outpatient setting, who has maybe an example or two of folks with OCD with whom you have worked? Anybody? Excuse me. Have y'all worked with anyone with OCD? Jennifer, you've worked with someone? Karen, you've worked with someone? Just in a word or two, what was their obsession or compulsion? Or both? Counted and locked? Sure. Gotcha. Counted and locked. So some symmetry with that repetition of numbers. And compulsions of doubt when people need to do and redo things. Washing hands, sure. Compulsive washing often related to intrusive thoughts about contamination and being dirty. Those are perfect examples. Remember, for a disorder to be a disorder, it has to be a disorder. The behavior, the symptom needs to result in clinically significant distress or impairment. The person needs to be really bothered by this. And one of the main features of these obsessive thoughts is that they're unwanted. When you look through the DSM criteria, an obsessive thought is unwanted. It is spontaneous, almost like a reflex that you might have, or a sneeze. It's automatic. You can't stop it. You don't initiate it. It's like a reflex or a tic, almost, you could say. Very uncomfortable. The obsessions can be things like sexual images, doing inappropriate, illegal sexual actions, doing violent behavior against other people, running over people in your car. And it's not, they don't want to do it. They've never done it. They know it's terrible. They know it's like, oh my God. It is ego dystonic. The person knows, whoa, this isn't me. This isn't my personality. This isn't something I've ever wanted to do. And so you can imagine the guilt people might feel about having these thoughts, because they're so counter to anything that the person actually believes in or stands for or values. So it's very discrepant, very distressing. And with the compulsions, it has to take up a lot of the person's time. Compulsions may not necessarily be distressing. They're often comforting once completed. The person feels better once the action has been completed. So the compulsive behavior in and of itself may not be distressing, but it will take a significant amount of their time, like I'm late to work. I can't get anything done because I'm having to wash my hands again and start over. If something's out of place, well, I have to completely go back through my house and put things symmetrically back in a certain way. I leave work and then start worrying, oh my gosh, did I turn off the stove? Did I lock the door? Did I close the garage? So you go back home to check it. You leave for work again and the exact same thought, even though you just checked it. You got to come back. So significant, time consuming. And there is, with some of these things, there is a magical thinking that Dr. Fogger's mentioning, that there is some kind of magical thinking, almost delusional component to some of these compulsions, that if I don't do this, then something bad will happen. Or if I don't keep things perfectly 90 degrees, everything 1 inch from the edge, all things stacked in threes, even heights, envelopes, paper towel, toilet paper. If I don't keep everything, even something, I just know something bad is going to happen to somebody. That's not actually based in reality. There's no evidence that how your physical space is organized is going to have some, but again, like we talked about last week, in those worry loops where a thought isn't necessarily filtered or corroborated with other evidence, it equals, the thought turns into an impulse that has to be acted upon, or else there is this sense of pressure to do so. And like Dr. Fogger mentioned cravings just now, the difference between an impulsive behavior, and a compulsive behavior is when you think about a pulse just as a beat in time, which is, when we say pulse, that's what we mean, a pause. An impulsive behavior is a behavior with a lack of pause. Ooh, I want to do that. That sounds good. Ooh, there we go. Dopamine. There we go. Nucleus accumbens. This is exciting. This is awesome. It's behavior without a thought. A compulsive behavior is a behavior with way too much obsessive thought, perseverative thought. That the person, they're not doing these compulsions because they want to or because it feels good. They're doing it because they can't not do it. And that's a big distinction, that there is discomfort associated with a lack of completing the action. And, our brains have a way of, when we feel distress, we come up with a reason for it. We map a reason onto our discomfort. It's why people with GAD see problems and disasters everywhere, because they are so anxious. Someone with a compulsive behavior, because they feel this distress, they say, well, surely something bad will happen. I feel like something bad's going to happen if I don't do this. Well, I guess something bad will happen if I don't do this. Well, no, it is actually the inappropriate connectivity in that striatal thalamic cortical loop that this behavior needs to happen, or else distress is maintained. And then if they actually do it, well, then there's relief. They're back to baseline. So with any other feature, not due to something else. And there's some specifiers now if the person has insight, which could be relevant for treatment. The person is really motivated and they want to change this and they want to do this. Well, it'd probably be a good idea to get them into a behavioral therapy to interrupt that compulsive behavior, instead of just letting it recycle and recycle and recycle. But if the person doesn't have any insight, then it may be important to try to reduce the severity of the OCD, provide some education, provide a medication to reduce the severity of it, so then you can start a conversation about behavioral interventions. Tics are highly comorbid with OCD. It is a disruption in the striatum, whose job is to filter out, this is what you want to do and this is not what you're going to do. It's involved in impulsivity and behaviors just being initiated and going. And you can have obsessive thinking increased by real dopamine enhancing agents like cocaine and like meth, stimulants, ADHD medications. You can have kids prone to tics who get on stimulants, ADHD medicines, and then the tic gets much worse. Will make sense because dopamine is responsible for controlling the filtering activity of the striatum, which is impaired in OCD. People say that. Have you ever heard anybody say, "Oh, well, I'm kind of OCD. I'm real OCD." Yeah. OCD and bipolar are probably one of the more misused psychiatric specific terms. And, everything exists on a spectrum. Everything exists on a spectrum on which all of us exist. So different degrees. And it's often when people are talking about that preference for symmetry and order is when people start thinking OCD, using it casually. So maybe that makes some people really great OR nurses. It's all about order and repetition and symmetry and cleanliness. That'd be actually really good, I guess. We talked about obsessions. These are unwanted, intrusive, distressing images. I could pull up real quick, maybe kind of sort of. I tried to pull this up. I don't know if y'all can even see that or if it's too small. But there is a screening measure for obsessive compulsive disorder called the Yale-Brown Obsessive Compulsive Screening Instrument, Symptom Checklist, however you want to call it. It's available in a PDF online, and it's a way to assess someone for obsessive compulsive features and identify specifically, are they obsession dominant, compulsion dominant, are they both present, and how severe is it? And they give some really great examples. You provide a little patient education and then let the patient fill it out. The different subtypes, I guess you'd call it, of OCD are, let me get back to where I was, sorry. Here we go. There are certain patterns of OCD. There are a few kind of rogue. Some folks have it, but there's also seems to be some consensus of the way that obsessive compulsive disorder tends to present in people. The most common patterns, so the way it's going to present most in folks, is obsessions of contamination, concerns about getting a disease, being dirty. So you can imagine these will be folks who wash their hands a lot in a magical thinking kind of standpoint. If I wash my hands a lot, then that'll protect me from this. So that'll be a big one, and it's pretty easy to assess for that too. Just you can think of ways to try to evaluate someone in a verbal interview for this. Do you find yourself washing your hands a lot, or thinking about how dirty phones are and doorknobs are and trying not to touch things? The obsession, the intrusive worry thought, shouldn't call it worry, the intrusive thought of doubt. Did I turn that off? Did I run that red light? That bump in the road, oh my gosh, was that, did I just hit something? Did I just hit somebody? And then there is this worry, what if, did I? And that results in people needing to check. Well, let me go back and do the lock 3 times. Let me come back. Let me go do the lock 3 times. 5 minutes later, I wonder if I locked the door. So those are examples of obsessions and compulsions paired. But some folks may have just an intrusive thought, just an intrusive image. And then symmetry, that's folks who want things color coordinated and organized, and things need to be a certain way. There's a certain way visuospatially for things to be. Certain numbers, that people like things in 3s. I worked with a patient who 3 was his number, and he had to buy things in 3s, consume sandwiches in 3rds, consume a can of Coke in a 3rd, and if he started to drink it and maybe it tipped over and spilled some out, well, he would throw it away and he would start again. Because there is, to not satisfy the compulsive behavior is very distressing. I think 3 is probably one of the more common numbers that people would pick to be their sort of magic number. Again, there's a bit of a magical thinking component to this, but that doesn't necessarily mean it's a problem or a disorder. 3 also has religious significance amongst, Judeo-Christian history, so it's there's some sentiment and some comfort in that too. So the course, often, like many disorders, will present after a significant stressor. Remember, stressor, situational, medical, environmental, cortisol goes up, hormones change. That changes the chemical environment in the body, which makes genes present differently. Genes might wake up, and symptoms that were never present now are present. With OCD, folks, because most of the time people are aware that this is atypical, so they will hide it. This is something that you may not learn about until you ask the person directly. And interestingly, in DSM-5, hoarding used to be under OCD, but now hoarding disorder is its own entity. Which, like most, and I'm not saying that OCD or hoarding is a delusional disorder. Don't hear me say that. The underlying mechanism, the physiology underlying these different presentations are very similar, and we know that a delusional disorder is tremendously difficult to treat, as is hoarding, as is obsessive-compulsive disorder. It can be difficult to treat, and we'll talk about medicines a little bit later. There are certain SSRIs and a TCA that's FDA indicated for OCD, but what you find is that you have to get the dose higher than the typical higher range to get significant symptom improvement. This is a 1 to 2%. 1 to 2% of people on the planet have this. This is not a common disorder. women will have it more than men, but younger. And as you see, a fourth of the people who develop OCD develop it young. And younger men or males outweigh female patients younger, but as you age, there is a switch and it ends up with women end up having it generally more than men. So that's kind of interesting. So OCD with boys, something you want to ask about. And don't be shocked if they say, well, yeah, I kind of do, kind of repeat these phrases in my head and I count my steps and it drives me crazy. I can't quit thinking about it. The equal, slightly greater, if I could do a equal but maybe slightly more. Thank you for pointing that out. I was saying one thing and meaning that and this. In adulthood, it more so averages out. Women stay tiny bit negligibly so. But really, kind of the take-home point is with younger people, kids, it will present younger with boys than it presents with women, but then women catch up as time goes on. And not a huge surprise, really, when you think about if this is a striatum involved issue, the increased presentation of impulsive, more motor dependent ADHD is more of a presentation in boys young than girls. So there's an age effect with these things. Most of the time by early adulthood, this isn't going to present at 50. It will probably present in teens and early 20s. With specific comorbidities, this is a real they're all medically driven, but this one has more comorbidities than others. In particular, tic disorder, Tourette's disorder, which is a filtering, it's a gating of behavior issue. And thoughts are behaviors that you just can't see them. So, studies, they do studies and they do MRIs, and there's a lot of functional MRI technology now that lets you actually look at the brains in action of people with different disorders and see, well, are they similar or different to people who don't have this disorder or have other disorders? And they're checking for metabolites of neurotransmitters in the system to see, are these people higher on serotonin? Are they lower on serotonin? Are they higher on this or lower on that? And the studies are indicating that there seems to be excess glutamate activity in certain brain structures for people with OCD. And glutamate is excitatory. It's going to turn things on and make them more active. And the structures where this seems to be the case for folks with OCD are structures involving, again, motor selection and sustained attention, and the filtering out of things that are irrelevant versus relevant, which really is what you see in OCD. It's a difficulty filtering out, well, is this relevant? Is this based in reality? Is this not? What is this thought, this behavior's relation to the other data in my environment right now? What other information do I have coming in? And there's a mismatch with OCD between what's believed to be true and what everybody else would say is true, as far as these obsessions and fear of germs and doubt and need for order. Something bad's going to happen if I don't XYZ. And they can see altered activity on the structures related for those kinds of behaviors. You have different brain structures and systems who are monitoring your internal experience, monitoring your external experience, a separate system whose job is to switch back and forth between the two. It is fascinating. They look at genes as well for kind of mapping the genome, I guess, of, that's probably not even the right word. But the genes most associated with OCD, and what that research indicates is that folks with OCD have the most genetic similarity to people with seizure disorders, and interestingly, also people with certain kinds of cancers, and the researchers don't really know what that's about. But what is the issue with seizures? Well, it's excess glutamate activity in the brain causing kindling and then rampant, overwhelming firing of areas. And that's what they see for folks with OCD too, is that excess glutamate activity in some gatekeeping structures. Not a surprise. Treatment of OCD, we mentioned there is excess activity and inappropriate activity in gatekeeping functions, lack of appropriate interaction between internal monitoring and external information coming in. This link right here will take you to an awesome website. I think it's Texas Medical Center, University of Texas Health Systems, and they have a neuroscience course, online course. I don't really know what to call it, but it gives you a great description of the striatum and its involvement with filtering activity, do this, don't do that, the role of dopamine in promoting good, deliberate responses and inhibiting sort of extraneous, unnecessary, irrelevant responses. So that's a pretty cool website to go to. I do recommend. Dopamine, we're speaking of the striatum and we're speaking of dopamine. If you get dopamine too high, you can get schizophrenia, you can get substance-induced psychosis, you can get delusional thinking, you can get perseverative thinking. I can't get off of this. I can't get off of this. Like I got a loop that I can't get out of. I can't interrupt this. You can also have tics. So this is similar malfunctions with different presentations. So dopamine, you probably wouldn't want to boost dopamine in the treatment of obsessive compulsive disorder. You may want to lessen dopamine activity. And a way to do that is SSRI, selective serotonin reuptake inhibitors, to try to correct some of that glutamate excess activity, try to normalize the dopaminergic activity. Serotonin on those 5-HT2A receptors, and more in some areas than others, serotonin can lessen dopamine release, can slow dopamine release. It can lessen norepinephrine release. It can have a calming, a less excitatory effect in the brain. Serotonin encourages GABA to be released at those 5-HT3 receptors. Says, hey, go ahead. So it has a calming effect when we're talking about these symptoms. I know in some cases people can have kind of activating responses to serotonin, and there's always that to SSRIs. That's always possible. But generally, as a class, enhancing serotonin through these mechanisms will have a lessening effect on that perseverative worry, the impulsive, the need. Because dopamine drives behavior. And if you can lessen it, then you may lessen the urge, the drive for the behavior, which in depression is a problem. People don't want to do anything. There's not enough dopamine being attached to any behavior. Nothing sounds good. Nothing seems fun. But when that mechanism is wrongly attached to behaviors, you end up with people feeling just determined. I must do something that is actually not life-sustaining. And Dr. Fogger is is our resident expert in addictions, which is when behaviors become. Oh, can y'all hear me? Wait, I'm gonna pause. I will pause. Can you hear me? Sorry. I don't know where my mic is. There's a good chance that I'm covering it up, but yeah, I think I might be covering it up by accident when I move this around. So anyway. It's not you, it's me. So yeah, just say, stop, if that happens again. You want to know the FDA indications for OCD because this is a very biology heavy issue. Tic disorder is strictly physiologically driven. Almost think of these compulsions as, and these obsessions as, it is almost like a tic. It just happens, it's there. So it's going to require a physical treatment to be involved in treatment. There's also therapies to help people, because there is this fear of, if I don't do this, something bad's going to happen. Well, no, that's actually not true. So you need to expose the person gradually. And this is something a therapist is more likely to do, to have time to do. Oh, there it goes again. I'll wait. Is it back? No, it's not back. Okay. I'll be quick. So, I get off my train of thought so easily. Oh, thank you, that the person has no, I'm not passing out candy. They're trying to jam my signal out here, so I will go pass out candy is probably what's going on. But you would tell the person would say, okay, I really want to wash my hands, but you deliberately, they wait and they know I'm actually not going to do it. And you just have them sit through not engaging in the compulsion. And then the urge goes away. The urge is not satisfied, so relief is not associated with the behavior because you're just trying to desensitize them to that. But our role will be assessing for it, maybe with a Y-box, tracking severity over time, starting them on a medication, and doing appropriate follow-up. We were going to mention a little bit. We were going to mention a little bit about PANDAS. Anybody heard of this? You heard of PANDAS or PANS? Pediatric autoimmune. It's a cute little name for a disorder that primarily affects children, but it's not a cute thing at all. I included a citation down there at the bottom if y'all want to find an article. This was recently published treatment guidelines from published in the Journal of Child and Adolescent Psychopharmacology. Oh, there it goes again. I'll tell you what, I'm touching something that I don't know what. This citation at the bottom will take you to, if you do Thiemann et al. 2017 PANDAS, it'll take you to treatment guidelines for this. Now, we just want to introduce this concept that some people develop OCD after being exposed to some unknown triggers and some known triggers, in particular, strep. Now, strep is a nasty critter because you can end up with structural damage to your heart and rheumatic fever and these kinds of things. But a child may be sent to you from the pediatrician because just all of a sudden they develop OCD symptoms like over the course of a week, and they never had them before. So PANDAS Well, goodness gracious. Canvas
Simone,
is
by the time that you realize that you're not in focus with your voice, the focus comes back again. So we just tell you that we can't hear you, and when you see that, just repeat what you just said. Usually the last two sentences are fuzzing out.
I got you. Well, that's really unfortunate. This happened to us once before. Let's see. So if someone presents to you referred by primary care, probably, because this is this is essentially an autoimmune response to some infection, and the result is involvement suddenly in the system, that CSTC loop that we're talking about. But it is usually post strep infection, but it's not always post strep. It could be other things. But this is some biological or chemical assault that results in an autoimmune response with subsequent OCD symptoms. I have these here. And this will occur over just a week or so. This is not typically how OCD presents, but it'll be a very quick, abrupt onset of OCD symptoms. 70% of the time there will be a tic disorder. 90% of the time there will be separation anxiety disorder. And a vast majority, I don't have a percentage, there will be eating restricting behavior. So isn't that interesting? So if someone comes to you with, say, oh, this child has either developed OCD so quickly, and then there's also separation anxiety, which is new, eating and drinking restrictions, which are new, you're not just dealing with, stats on this. I did not come across stats on this in that article, which doesn't mean it wasn't there, just means I missed it. But this is significant enough for treatment guidelines to have been established. This is really a disorder of exclusion, but treatment will eventually involve psych mental health to manage anxiety and OCD, but requires collaboration with the medical team to reduce the inflammation. Sometimes there's even immunomodulatory treatments, because this is the immune system attacks structures responsible for response inhibition and the striatum and that gatekeeping function. So it is really OCD type symptoms with other things following an infection, which most of the time is strep, but they don't necessarily know that. So that's interesting. It's kind of just like speeding up the genetic changes that would result in some, when you think about methotrexate and diseases for anything to oppose in autoimmune kind of disease, big courses of steroids. Sure. Talking about the immune modulatory treatments that we were mentioning, things like lots of steroids, things like those autoimmune medicines that people take for, psoriasis and IBS, and but again, not things that you will be responsible for, but you would want to know why this young person with OCD is on these other medicines. But really, check this. Go to Lister Hill and search. I won't even try to say that name. Tiemann and about 10 other people. 2017 article on treatment guidelines for that. We'll go over this fairly quickly. Separation anxiety disorder is what it is. It's significant distress and impairment an excessive fear of separation from attachment figures that usually presents prior to, before preschool. There's that, we'll talk about on that next slide, normal stranger anxiety, sometime between, around 2-ish years old, when kids realize, oh, who is this person? This person might not be okay. But this is beyond normal, kids who are kind of clingy. This is distress. This is crying. This is bargaining. I don't want to leave. This is, I don't want to go to school. I don't want to do a sleepover. I don't want to leave my house. I don't want to be by myself. It is excess fear and anxiety specifically related to something happening to the primary caregiver, the primary attachment figure. And anxiety in younger people, school age and under, will have more of a physical presentation. There's not language and that real easy symbolic, that more easy symbolic abstract communication of, oh, I'm so worried and I'm so nervous and I'm so scared. So it may present in 5, 6, 7, 8-year-olds, maybe older, of, oh, my head hurts, my stomach hurts, in anticipation of going to school, in anticipation of leaving for, a trip, or I go out to a friend's house and then it gets dark and now my stomach hurts and I need to go home. But it's not anything and everything. So this isn't generalized anxiety disorder. It's not a short-lived phobic response to animals or to the doctor. This is specific worry that something bad's going to happen to your parents. They want to check in with their parents, make sure their parents are okay. They don't want to be apart from them for too long. And in people under 18, these symptoms need to be persistent for 4 weeks. Separation anxiety can develop in adults. This isn't exclusive to children. It's more common in younger people. So this could be excessive worry about, are my kids okay? Is my spouse okay? And discomfort from being away from them, wanting to check in with them a lot. Parallel process. It's just about attachment figures, people to whom they are very close. But it must last for 6 months in people over 18. And again, with an adult, it's not, I'm worried about my family and terrorism and finances and my grades and my job. It's specific to important attachment figures with compensatory behaviors that cause distress and impairment. The age ranges, like the cutoff, 18, that younger people needs to be present. It just doesn't need to be present as long to be considered, I guess, a significant issue for young kids than it does for older people. And as you age, you would, logically, as the person ages, young kids will be the attachment figure, the concern will be the parents, but as you age, it no longer is the parent. It may completely go away, or it may transition to other attachment figures, important attachment figures. Again, you're looking at 1 or 2%. But in kids, and anxiety disorders are they're not common in children, but if a child is going to suffer from something, anxiety is high on the list. So you just want to You have parents bringing their kid in because they're having all these headaches and stomach aches and they don't want to go to school and they don't want to go to camp and they don't want to hang out with their friends anymore. Go to sleepovers, parents having to go get them in the middle of the night. You'd want to say, did anything change prior to this? Did y'all move? Was there a death? Anything kind of stressful or unusual? Because it may just be kind of a temporary response to that stress. But you just want to be able to distinguish this from generalized anxiety disorder. They're not worried about everything. It's specific to attachment figures, something bad happening to them. And it can be present in adults. And really in both of these things, medication shouldn't be your first choice for either of these things. This is something that cognitive therapy is appropriate for because it's about enhancing self-regulation, enhancing relaxation skills so that the person can de-escalate when they get upset and engage their brain again. And then therapy to challenge, know what's really going to happen. What evidence do you have? Let's kind of walk through how this is going to go. So cognitive therapy is really what you need to do for separation anxiety. And with kids, that involves teaching the parents how to teach the child. Anxiety management, deep breathing, progressive muscle relaxation. Let's talk about, what are you worried about? What's going to happen? Well, has that ever happened before? No. And, you just go through the same process. The last one that we were going to talk about, last but not least, is social anxiety disorder, which used to be called social phobia, but it's not social phobia anymore. This is significant fear about social situations, not being in a crowd, not being somewhere I can't escape. That's more agoraphobia. It is specific to saying something embarrassing or saying something stupid. So it's not just any old person. They may be okay in a crowd where they're anonymous, but if I have to talk to somebody, or I have to go up and introduce myself to this person, that's when a near phobic. So you think about fear circuit versus worry circuit. That fear circuit is activated. So this isn't, I don't like people. This isn't, I feel nervous in crowds. I'm watching my back, that kind of stuff. No, this is specific that in a one-on-one interaction or in a crowd of people, if I'm giving a talk or something, oh my gosh, I'm going to do something stupid, and then my heart rate goes up and I'll start sweating and then my voice starts shaking. The mic went out. The mic had social anxiety disorder. We're almost done, so I appreciate y'all being patient with all of those cutouts. But this is people who feel very anxious at the thought of saying something stupid. So they're okay with people they know. They're okay with people they're comfortable with, but it is specific to, I'm going to do something stupid, I'm going to say something stupid, I'm going to embarrass myself. And there's a big, again, a phobic, meaning fight or flight, fear response that lasts for at least 6 months. And you could imagine how this would make people avoid things, have a more limited social life, a more restricted social life. I don't want to order pizza. I don't want to call Domino's and order pizza because what if I say something stupid? What if I embarrass myself? Working with other people, how impairing this would be. And treatment for this, again, this is a phobic sort of thing. The treatment should start with cognitive therapy, with learning physiological management, how to induce relaxation when anxiety is increasing, like deep breathing. I'm going to trick my body into thinking I'm calm because I'm going to breathe really slow. And I'm going to tell myself that this is fine. This is not scary. This is not a problem. I'm okay. This is fine. So you start there, but if the person continues to have impairment, then SSRIs would be the way to go. And again, when people are really in tune, to signs that the anxiety is increasing, that if you can interrupt that initial sympathetic response, you lessen the likelihood that it gets out of hand. Kind of like we talked about the heart beating faster and the kind of little sweaty palm says, oh God, I'm going to have a panic attack. And then all the fear increases because suddenly you have a real threat. Like, oh, I have signs of this now. This is a problem. It gets worse and worse. You can interrupt that with beta blockers, something to prevent your heart from beating harder and faster, like propranolol. You may see some people breathing slow, breathing deep, getting plenty of oxygen in there. You have so much oxygen that your heart doesn't need to beat as fast to move it around. So breathe slower, and you slow things down. Breathe deeper, you slow things down. So again, like with separation anxiety in childhood or adulthood, like social anxiety, start with cognitive interventions. These are going to be people who may come to you saying, oh, I get so nervous talking to people, and it's been this way for years, but it's really starting to hinder my work performance. First thing you want to do is recommend behavioral interventions so they can manage it themselves. Refer them to a therapist, and look, if that may be all that they need to manage this. They go straight to freaking out and they lose it. But if they can have some successful encounters and they can manage it better, then maybe they don't need medicine at all. And how wonderful is that? But for some people, medicine is indicated. With OCD, definitely. Like with severe depression, you need medicine on board. Therapy too, but medicine's non-negotiable. With active mania, medicine is non-negotiable. With social anxiety disorder, it's negotiable. Which is really similar with, this is a slide y'all don't have, but feel free to jot down notes. We're just introducing this in advance of the spring. Oh, y'all do have this one? Oh, wait. Let me see. Hang on. How about this one? Rats. See, it just took a while to load. Not a huge deal. Just jot down a few things. There's not actually a lot of information here. So not major issue. But for when you're working with kids, with GAD, with separation anxiety, with adjustment disorder, with anxiety, and anxious kids who are just dealing with hard stuff. They've moved. A parent got sick. Their parents separated. The child got sick. Whatever it is. Anxiety is your body on alert. It's a good thing. We're designed to do it. But with little kids, with younger people, really with anybody, don't give medicine to people when it's not indicated. In particular with pediatrics, because it is harder to know confidently diagnostically what you are seeing in younger people. because off the bat, these disorders are less likely to present. Something's unusual that the child is presenting with this in the first place. It's not typical to be tremendously clinically anxious at 8 years old or 12 years old. And cognitive therapy, CBT, needs to be your first recommendation. CBT has to be number one with kids. I recommend it for everybody. So the first thing you'll do, the child comes in, whether they have, GAD or again, adjustment, separation, those kinds of things. Educate the family about what the symptoms are. Make sure the parents know emotion regulation, relaxation skills so that they can reinforce to the child and practice with the child. Having a schedule, having predictability, these are basic things that not everybody knows about. I mean, a bedtime routine, a bedtime schedule, eating at a regular time every day. Consistency can be tremendous. Predictability is so helpful. Encourage practicing these anxiety management skills. Make sure the parents know. There's a really cute book called What to Do When You Worry Too Much. And it's cognitive therapy, but in sort of a story that the parents and the kids can look through. And it's a really great little book. Kids seem to like it as far as how to deal with worry from a cognitive therapy standpoint. Another resource is called COPE, C-O-P-E. It's very expensive. Coping Cat. What to Do When You Worry Too Much is a precious little story-based book that parents can go through with their kids. It's more like a story than like a treatment manual, but there are lots of manualized cognitive therapy treatments for kids. One is called Coping Cat, which is also, it's more clinical than the What to Do When You Worry Too Much book. But Coping Cat teaches body awareness, how to label your feelings, how to recognize feelings, how to respond and relax. That is often all the child needs. If they had better anxiety management skills, medicine wouldn't even be an issue. And we don't want medication to be the first thing if it's avoidable. Second or third or fourth or down the line, you don't want the child to be in distress, but you need to get the environment, make sure the environment is capable of helping the child manage. Medicines won't make up for environmental deficits in routine or skills or knowledge. So be sure you can point the parents in some directions. Refer the child to a child therapist if needed. But sometimes that's not enough and the child is still very distressed and very anxious. A lot of times, these are off-label, but hydroxyzine, the Benadryl relative, can be calming, can be sedating. Clonidine will be used off-label for anxiety in kids. And there are SSRI, there's no SSRI indicated for anxiety in children, like GAD or panic or separation anxiety, but SSRIs have been studied and determined to be safe as far as OCD goes in kids. So, if there's still this, if there is OCD, and we're not talking about anxiety necessarily anymore, but there is no FDA indicated anxiety medicine for kids. Doesn't exist. But if you're talking about OCD, there are. And it's Zoloft, Prozac, the only time you'll ever see Luvox written, and then the TCA, clomipramine. And you start low, as low as you can. It says 20 of Prozac, you do 10. 12.5 or 25 of Zoloft. and you titrate up slowly. Because remember, these young folks are maybe even more in touch with physiological, like sensory changes in their body of, oh, I'm starting to feel anxious, my stomach hurts, I feel kind of jittery, my heart feels funny, my heart's kind of fluttery. So you don't want to make dose changes too quickly. So again, there's not a medicine for pediatric anxiety, not one FDA indicated. SSRIs are indicated for pediatric OCD and some for depression. So if therapy doesn't work, if these skills don't work, and maybe you've tried preventive hydroxyzine maybe around difficult transitions, or maybe you've tried clonidine and the child is still in significant distress, then SSRIs would be the next logical conclusion. In extreme cases, you will have, in extreme cases, you may have antipsychotics, real low dose antipsychotics like Risperdal, benzodiazepines. But again, these are not things that you're going to just suggest. Your nephew doesn't? Okay, Lauren Pearl has a comment. Doesn't have OCD, but propranolol helped his anxiety. Oh boy, new baby brother stole the thunder. Yeah, it's a pretty significant trauma to a young person that suddenly his caregivers are giving an awful lot of time and attention to somebody else. Mm-hmm. Yeah, if the system can support better coping behaviors, then great. And sometimes that just isn't enough. So our job is to educate about what's indicated. You don't want to throw medicines that aren't necessary at small developing brains. So you go from a risk-benefit, cognitive therapy first, manualized treatments, relaxation, get the parents involved, and sometimes even getting the parents recognizing that the child is in distress, and just getting the parents attentive to and responsive to sometimes it's this process change. It's not necessarily what skills they go over. Sometimes it's just the reorientation of the family back to the needs of the weakest member. One way to look at especially anxiety disorders in kids is you have a family system and stress is applied to the family system, and the strain will manifest itself in the weakest member. And that's with anything. And that's with everything. It's the loose lug nut that flies off the wheel. It's the cracked board that breaks when you're walking around wherever it is that you're walking around that has boards. But think about a family system exactly, the identified patient, that when the stress is applied to a system, the weakest member will show the strain. And just by having the family reorient itself and attend to the needs of the child, kind of focus the resources back to the member who needs nourishment, sometimes that's all it takes to get. You could say, how about y'all have game night once a week? You're not going through some anxiety manual, just plug back in. Yeah, and when you work with kids, you're actually working with families, because the child doesn't have the experience, the cognitive resources, the emotional resources to manage this. You have to teach the parents how to nurture this child and whatever the need is, so that they can recover, they can get better, they can get back to normal. I refer to it as emotional skin to skin. When infants are born, they can't regulate their own temperature, so you have to physically put the child in contact with an adult. Because the child's thermoregulation then becomes an extension of the adult's thermoregulation. It's the exact same thing with emotional regulation. The parents need sufficient capacity to regulate emotion to work the child through it until the child can do it on their own, but it has to be done for them and they have to see it done. And again, that's more just life stuff. There are going to be times if the child's meeting criteria for GAD, for panic, for OCD, then medicines will be indicated. You got to try the therapy first, though, because that is probably because medicines won't make up for that. Okay, that's my story, and I'm sticking to it. Last slide, exam preparation. You want to be familiar with the SADC readings, diagnostic criteria, FDA-indicated medications, off-label medications. What drugs do we use for these different disorders? Those two different circuits. And again, that was a extremely brief introduction as to the differences between treating child and adolescent anxiety. Different meds are indicated. You start lower, you go up slower. And that's all I got. I've taken y'all 10 minutes past time, and I apologize for all of these sound problems. If you have any questions about anything, that you did or didn't hear, Sabina is on it tonight. Goblins in the mic, exactly. Ghosts in the system. But yeah, any questions about any of that, don't hesitate to shoot an email. Let's shut it down so everybody can go trick-or-treating. Have a fun, have a very pleasant Halloween night, everybody. Thanks for hanging out. And look forward to hearing from y'all soon, okay? Adios, everybody.
Good night, everybody. Good night, Simone.
Good night, John Boy.